Let's get straight into it. This is a high-density briefing on the April 2025 RCEM Best Practice Guideline for Managing Suspected Unidentified Poisoning. Our objective here is simple: to get these critical updates into your clinical practice immediately. So here's our roadmap. We'll cover the core practice changes first, then the new systematic approach, toxidrome-based treatment, targeted interventions and ECGs, key pediatric points, and we'll wrap up with a summary and safe disposition. All right, let's begin with the most critical mandates. What's actually changed in this new guideline?
Okay, so the fundamental shift here is a move from being reactive to being proactive. It's really defined by what we must stop doing versus what we must start. First, what to stop. We are no longer waiting for agent identification to begin treatment. That delay is no longer acceptable. And critically, we have to stop using point-of-care urine toxicology screening. The evidence shows it's largely inaccurate and can be misleading. Now, what to start doing? We must initiate treatment based on toxidrome recognition, period. We also need to modify our systematic approach to include the CRESS assessment, which we'll dive into. And finally, we need to be actively using toxicokinetics to predict the likely clinical course of our patients.
So these new mandates are all built into a revised systematic algorithm. Let's review that now. This flowchart is our new standard of care. Notice the very first step, and it's a crucial one: team safety and PPE. From there, we move directly to an integrated A to E assessment, which now includes CRESS. Take a look at the branch points for decontamination. The key is that these should never delay life-saving interventions. The flow then moves logically to investigations, identifying the toxidrome, and considering toxicodynamics. And of course, with continuous access to ToxBase and the National Poisons Information Service. So what is this CRESS mnemonic? It's a critical new addition to our primary survey. It stands for consciousness, respiration, eyes, secretions, and skin. It's really designed for a rapid, structured assessment of the key toxicological signs to help you build that toxidrome picture right from the moment you meet the patient. The guideline is also very clear on first-line investigations. An ECG is mandatory in every single one of these patients, and you'll likely need to do serial ECGs. Same goes for the venous blood gas. Your standard blood panel should include FBC, UNEs, LFTs, magnesium, CK, and clotting. Plus, of course, specific assays for paracetamol and salicylates. And this is vital. You must calculate the serum osmolarity and the anion gap to hunt for those toxic alcohols or a hidden metabolic acidosis. Right, let's get to the core principle of this entire guideline: using early toxidrome recognition to guide our immediate therapy. This table is really your primary clinical reference. Let's run through them. For opioids, you're looking for that classic picture: reduced consciousness, respiratory depression, and pinpoint pupils. Cholinergics, think organophosphates. This is your wet patient with excessive secretions. Contrast that completely with anticholinergics: agitated, flushed, dry skin, and dilated pupils. You all know the saying: mad as a hatter, blind as a bat, red as a beet, hot as a hare, dry as a bone. Sedatives/hypnotics will present with a more generalized depression, while sympathomimetics are the opposite: agitated, hypertensive, tachycardic, with dilated pupils. Recognizing these patterns is now absolutely central to management. In this quote right here, this underscores the single most important message of the entire guideline. For any compromised patient, you treat the toxidrome. You do not wait for the lab to identify the agent. This is a life-saving directive. Okay, let's move on to specific interventions within that modified ADE assessment. And we'll focus heavily on the critical ECG findings you have to be able to spot. Looking at the ADE approach through a toxicology lens, you'll see some specific considerations. Under airway, have a very low threshold for early intubation. For breathing, you need to remember that pulse oximetry can be unreliable in cases like carbon monoxide poisoning or methemoglobinemia. Under circulation, it's all about the ECG changes. For disability, get on top of seizures early and always consider serotonin syndrome. And for exposure, you've got to initiate decontamination and manage temperature aggressively. So let's talk about that critical intervention for QRS prolongation. The guideline is unequivocal here. If you see sodium channel blockade, the immediate treatment is sodium bicarbonate. The dose is 1 to 2 milliliters per kilogram of the 8.4% solution, given centrally. Or, if you have to go peripherally, use a 4.2% solution over 20 minutes. This is an intervention you cannot delay. This table is fantastic because it links ECG findings directly to potential toxin classes. You see a prolonged QRS, you should immediately be thinking of things like tricyclic antidepressants or quinine. A prolonged QT interval points you towards antipsychotics and SSRIs. and bradycardia should make you suspicious for digoxin, calcium channel blockers, or beta blockers. Using the ECG as a diagnostic tool is absolutely paramount.
Now, when you do identify a prolonged QT interval, the Talkspace QT nomogram is the tool you should be using for risk stratification. It works by plotting the QT interval against the heart rate, and that tells you if the patient is in a high-risk category 4 arrhythmia. This then guides your monitoring and intervention decisions.
Now for a focused review of pediatric-specific points. It's not just small adults. There are deviations and high-risk factors inherent to this population. Right, managing pediatric poisoning demands a much higher index of suspicion. First, remember their physiology. They have increased transdermal and respiratory absorption. Second, and this is a safeguarding mandate, you must always consider non-accidental injury or neglect. For any unknown ingestion, you have to assume the worst-case scenario, that the maximum possible dose was taken. And finally, you have to be intimately familiar with those one-pill-can-kill agents, which all have their own specific management pathways.
We're almost there. Let's conclude with the core take-home messages and the explicit criteria for safe patient disposition.
If you remember nothing else, remember these 3 definitive messages. 1. Initiate treatment based on the toxidrome before the agent is identified. 2. In any pediatric patient with suspected poisoning, always consider non-accidental injury or neglect. And 3. Consistently apply that systematic ABCDE plus CRSSS assessment approach. The criteria for disposition are now very strict. A patient can only be discharged when they are both physiologically and biochemically stable, and, this is key, based on the toxicodynamics of the suspected agent, no further deterioration is anticipated. This is all about preventing those premature discharges and subsequent adverse events. And finally, the guideline leaves us with a critical question for our own practice. Is your department's antidote stock, specifically your Category A, B, and C antidotes, actually known to your staff and accessible within the mandated timeframes? Because departmental readiness is a non-negotiable component of patient safety in clinical toxicology.